بسم الله الرحمن الرحيم. يسعدني ويشرفني ان انا ارحب بحضراتكم جميعا في الشولدر سبيشاليتي داي. النهارده يوم مختلف، احنا معانا 12 سبيكرز من 5 دول، معانا اساتذتنا من جميع الجامعات المصريه. We have speakers from UK, from USA, from Brazil. Unfortunately, Professor Mauricio Raffaelli from Brazil has got a problem, so he will not be able to be with us. We have speakers from Germany, and we have speakers from India. Our first speaker will be our great professor, Professor Khalid Matarawi, Dean of the Alexandria Research Institute and Professor of Radiology. Professor Khalid is one of the eminent stars of radiology, especially in orthopedic radiology. Professor Khalid will have a very interesting talk about shoulder imaging. Thank you so much for being with us, sir.
بسم الله الرحمن الرحيم. يعني يشرفني ان انا اكون موجود النهارده مع القامات الكبيره اللي موجوده، ويسعدني ان البروفيسور اشهب عميد كليه طب بنها والصديق العزيز والسينيور بتاعي، يعني ان انا اكون موجود مع حضراتكم النهارده. واتمنى I hope in the next 20 minutes I will cover the tips and tricks for shoulder imaging. واحاول اكفر الاودينس بتوعنا ما بين اساتذتي وزملائي وما بين طبعا زملائنا الجونيور ستاف. ابدا دكتور محمد.
تمام يا فندم، اتفضل يا فندم، اتفضل يا استاذ.
And I have nothing to disclose. I have general rules for imaging in general. You have to be sure that you're examining the side that the patient is complaining from. Detailed history is important in medicine, but in musculoskeletal, you have to verify if it is a traumatic patient or non-traumatic patient. Especially in the shoulder, we have special situation for the shoulder is the cases of instability. You have to clarify with the patient if he has even a single attack of previous subluxation or dislocation. Where to look for what you are looking for? This is very important in MRI imaging. We have different sequences. We have T1 and T1 fat SAD, T2 and T2 fat SAD, PD, different sequences. You have to know where, what is the sequence you are dealing with and which orientation. At least you have to have 2 different orientation. If more, this will be much more important. The key will be talk about this in different. This is the Plotica Alexandrina from the CNMI city. I want to start with. Before to start, this presentation is dedicated for the MRI of the shoulder, but I need to remind myself before you that the mainstay of musculoskeletal imaging is the X-ray. Don't forget the X-ray. Don't drop it from your slide. The X-ray is very, very important. Of course, I will not go through the details of the X-ray, but the X-ray in musculoskeletal is very important, and in the shoulder, it's very, very important. Now we will go for the core of our lecture, the normal MRI of the shoulder. This is the AC joint. The AC joint should be the end of the clavicle, and when the end of the acromion should be in congruity with each other and will be the same level. This is very, very important item. If we have any change of this normal anatomical description, we may go for another pathology. The supraspinatus tendon, we see here in the coronal images, you can see here this is the bulk of the muscle. The tendon starts from the center of the muscle and reaches to its final destination in the footprint on the humerus to be inserted in. Now we go for the type. Where to look for what you are looking for? The type of the acromion, you have to see it in the sagittal image. You have type 1 here, type 2 here, this curved downward, and type 3, the most important is the hook here, and type 4 is curved upward. What is the key? You have to have a checklist. Rather than orthopedic, examining a patient for the knee, for the hip, for the wrist, you have to have certain points to be fulfilled if you are examining a patient. In the imaging, we have the same checklist approach, whatever you can say it, but you have to have certain points not to forget any item. The AC joint, the acromion, bursitis, rotator cuff, biceps, the marrow effusion, and of course, instability has certain points itself. Now we go for what's called impingement. The coracoacromial arch consists of anterior third of the acromion, coracoacromial ligament, and the coracoacromial. We have here a very important description is called impingement interval. The impingement interval is the space between the coracoacromial arch and the humeral head. This is the potential space. Anything that narrows this space can cause impingement. And we have to clarify one important point here, that impingement is a clinical diagnosis. So what is our role in it? We have to verify which point of this, which cause of this can cause the impingement. We are not diagnosis impingement. We help the physician, we help the physiotherapist to know which cause goes for the cause of subacromial impingement. The first to here we have the acromial clavicular joints with these large osteophytes that can cause narrowing of the subacromial space and causes impingement. This is what's called lateral acromial sloping. It's seen in the coronal images, and you can see here that the acromion is not passing transverse as it's usually. It's slightly laterally sloping and further narrowing the subacromial space. As I said before, the type of the acromion 3, hooking downwards, and we can see it in the sagittal images. The thickened coracoacromial ligament between the coracoid process and the acromion, that also narrowing the subacromial space. We can see here this spur in the acromion space. Sometimes we can see the lateral acromial sloping by itself, only the lateral acromion without osteoarthrosis. Another very important item here, the ossa acromial. The ossa acromial is unfused apophysis of the acromion. This is not diagnosed before 20 years, 21 years, especially males and females, whatever the age is. But you have to be very important item that you can see it in the last upper axial images. If we have this unfused ossa acromial, this is we call this. The inferior acromial opposite, as I said before, the acromion and the clavicle should articulate in the same level. Subacromial bursitis can also cause subacromial impingement, but we have another sort of impingement of the shoulder, what's called the coracoid impingement. The distance between the lesser tuberosity and the coracoid process, this slides the subscapularis tendon. If this is narrower than 11 millimeter, can impinge the subscapularis tendon. Another image is for the bibliotic Alexandria from the air. Of course, all of you know the rotator cuff. What we need to know about the rotator cuff? We have to know that the rotator cuff is normal, tendinosis, and then a small partial tear, and most of the partial tear is usually at the footprint, and then we have full thickness tear. And we have a very important point of conflict here. Full thickness tear, that does not mean that we have a retraction of the tendon, because sometimes we have a full thickness tear, but only a part of the tendon. But still, the rest of the tendon is still attaching, though there is no retraction. But if we have the full part of the supraspinatus tendon is detached from its humeral insertion, this we have what's called full thickness tear with retraction. Now we go for this. This is very important. In the sagittal images, we have two types. Types of sagittal. We can know what is the causes the integrity of the muscles, the important relation between the supraspinatus and the infraspinatus muscles. That again, the subscapularis tendon, we have to check with the subscapularis tendon. It's inserted into the lip of the bicipital groove. And of course, we can go for this type. This is what's called full thickness tear. This is the full thickness tear of the supraspinatus tendon without retraction. We measure this part, and we can go for the measurement of supraspinatus tendon. The partial thickness tear of the supraspinatus tendon is the footprint. This is very important entity to have to clarify for the physician. And this is very difficult to diagnose. The interstitial tear. The interstitial tear is part of the clinical diagnosis, as we said before, the rotator cuff impingement, subacromial impingement. Sorry. This is the type, another type of the full thickness tear, and we have this type of retraction. And we can see here all this thickness, all this area. We don't find the supraspinatus. This is the supraspinatus muscle is crumbled here, and we don't find the supraspinatus tendon in its normal place. This is to verify the prognosis of rotator cuff injury if the supraspinatus alone, if it is with the biceps, if it is with the infraspinatus, this lead to more grave prognosis. This is a very important point before surgery to have to know the bulk of the supraspinatus muscle. We can see here the coracoid process and the spine of the scapula. The bulk of the muscle should overlook this line between these two bones. If we have a long-standing injury of the supraspinatus, we can see here what's called atrophy of the muscle. If the atrophy changes to atrophy and fatty replacement, this will lead to unpleasant data or unpleasant effect after the operation. This is the you can see here the supraspinatus muscle is totally and evidently atrophied. This is called Guattarier classification for the bulk of the muscle. You can see here still, even with the injury of the supraspinatus muscle, we have injury. We have the muscle bulk is still there. Some fatty changes, a lot of fatty changes crossing from type 1 to type 5. If we go to for more and more fatty replacement, this is not good for after surgery, as we all know. We can see here that the instability have different items here. We have to check in the exam images here the anterior and posterior labrum. This is very important, as I said before, and the superior labrum for the slap lesions. Then we have different X-rays before we will go directly for the Bankert lesion, the famous Bankert lesion, anteroinferior labral tear with or without periosteal elevation and periosteal injuries. And we can see here this is very evident, and sometimes we may need to go for MR arthrogram to verify the subtle and small injuries of the Bankert lesions. And sometimes we have some special types we will go through with this. I prefer every case of subluxation, dislocation, and instability, we have to go for CT to detect. This is very evident bony Bankert, of course, but sometimes we have small Bankert, and we have some periosteal elevation that is not evident with the standard CT or standard MR images. Of course, we go for more and more difficult cases with this off track and in track, and of course, in 20-minute presentation, I will not go for whole this slide. This is very important slide because what's called PICO method. Sometimes with the recurrent shoulder dislocation, the humeral head will go to some injury of the bony glenoid that it's not broken. It's called the defective anteroinferior bony glenoid, as we can see here. If it is not measured before corrective surgery and we correct only the labrum without osseous correction, this will go for recurrent shoulder dislocation even immediately after surgery. This is the different types of the subluxations or instability, like Perthes disease and Hagel, of course, of the anteroinferior labral ligaments injuries, and the GLAD, if we have here associated cartilaginous injury, of course, the famous Alepsa here, and of course, the reversed types of less common, of course, the more common instability is the anterior, 95%, and the 5% only of the posterior dislocation with the reversed Bankert and heel sac, and polypsa, the reversed of the Alepsa. Slap lesion, I usually describe it only if it is superior labral injuries. They have different types, up to 16 now. That is, of course, it's not an easy job to describe, but extended subtypes of injury, it's very important to describe the bucket hand. Again and again, it's very important to work in a team to have multi-direction instability of the shoulder and minor shoulder instability. This is a clinical diagnosis. we in imaging, we don't have a rule here, but it's very important for our colleagues in the orthopedic to know this. I will describe this. This is another very important item here, the acromioclavicular joint injury. You have the Rockwood classification, very well known for our colleagues in radiology. You have to know that we have the acromioclavicular subluxation. You have to describe the superior acromioclavicular ligament, the coracoclavicular ligament, the injury in the trapezius and deltoid muscle. All these are very important in description of the acromioclavicular joint injury. We have another important item for the AC joint in our colleagues in athletes, the autoathletic, the weightlifting in the gyms now. The people are doing a lot of weightlifting. This injured the AC joint. Another item which is very important, and also again and again, the clinical diagnosis are led by your clinical diagnosis. The adhesive capsulitis, very important to know this, the normal axillary recess, and we can describe it and suggest that this patient may have this frozen shoulder with adhesive capsulitis if matching with your clinical diagnosis. This is a last point for me to describe in the MRI of the shoulders, that it is increasing and decreasing these days, the pectoralis major injury. A lot of our colleagues in orthopedic, they describe for the prescription, please, for MRI shoulder to diagnose pectoralis major injury, and this will not be covered with the standard protocol for the MRI shoulder. If you need to verify if there is a pectoralis major injury, yes or no, you have to go for pectoralis major protocol. This is the pectoralis major because we have described both types. You can see here a major injury of the pectoralis major here comparative to the left side. This will not be evident in the normal or standard protocol of the shoulder. So this is a quiz. What is this lesion here? You can see this in the leading related to the deltoid muscle here and here. This is a subacromial subdeltoid bursitis. Okay. Again, what is this? This lesion. This is lipoma. Why? Because this is T2, and in the T2 the fluid is white, but here is T1. This is not fluid. This is fat. The fat in T1 is hyper and looks like fluid. So this is another message. As I said in the start of the lecture, please you have to know which orientation and which type of the sequence you need to verify. Okay, finally, we have to look for what you are looking for. As I said here, the impingement, what is the cause? You are clinically diagnosed, and we're helping the cause. Rotator cuff, as I said before, normal tendinosis, tendinitis, interstitial tear, partial tear, full thickness tear with or without retraction. More and more involvement of the rotator cuff lead to bad prognosis. Of course, as I said, Goutelier, the muscle atrophy and the fatty replacement. Don't forget the AC joint. Don't forget the pectoralis major. Other tips and tricks for this person. Of course, I'm not talking about Obama, about the other person. These are two persons, but this is why radiologists need to have two different angles to verify their diagnosis. And finally, I want to thank you for your attention. Thank you.
Thank you so much, my dear Professor Khaled Matarawi, for this very interesting talk. I think, sir, every orthopedic surgeon has a very good knowledge about radiology, and I think, sir, you are the best one to demonstrate this to us. Thank you so much, sir.
Thank you very much, Dr. Ashraf, for sharing and for giving me this chance to be among these elegant and elite professors. And I hope to continue this cooperation between us. Thank you very much.
Thank you so much, sir. Thank you so much, sir. It's very kind of you. Thank you so much, sir.
Thank you.
Our next speaker will be Professor Osama Samir Garour from Mansoura University, Egypt. Professor Osama will speak about a shoulder examination stepwise approach. Professor Osama?
Yes, Mohammed, can you hear me well?
Yeah, I can hear you. Thank you so much.
Thank you very much.
Full screen, please, Professor Osama.
Okay.
Yes.
Thank you so much very much for this great opportunity to be here. Today
دكتور أسامة، هو الصوت بتاع حضرتك فيه ريزونانس جامد قوي يا فندم.
طيب لحظة واحدة. كده أفضل شوية.
Yes sir. Yes sir.
My name is Osama Garour. I'm assistant professor of orthopedic surgery at Mansour University. Well, basically, to me, the shoulder examination, or basically the examination, and is it clear, the voice?
Yes sir.
History taking and shoulder examination are a little bit overestimated and outdated. I mean, you can see the huge armamentarium of the diagnostic tools we had. Dr. Khaled now was talking about the MRI, which can capture every minute detail of the MRI. So, I mean, who needs the examination anymore? We can see this X-ray here. I think no one can argue that it is anterior shoulder dislocation. So what are we going to do for this patient? Of course, we're going to perform closed reduction, and then we will manage after that accordingly if it's recurrent or not. Here we have another second patient. It's a classic light bulb appearance indicating posterior shoulder dislocation. Of course, we need to perform closed reduction, and then we will manage accordingly after the reduction regarding the stability of the shoulder. Here we have a young chap who fell on the right shoulder with injury of the AC joints. We all agree that it's type 3 Rockwood classification. And of course, we agree that if this patient is not high demand, we will go for conservative treatment. And most of the literature basically come with pleasant outcome with conservative treatment for this patient. Another patient who complained, we can find in the MRI this minor incomplete insertional injury on the supraspinatus tendon. So I don't think that we need to go for any repair for that, and physical therapy, I think, would be enough. And here we have the last patient with a huge, complete full thickness supraspinatus. So I think most of us would agree for going for repair for such patient, whether arthroscopic or mini open, according to your preference. So I think we have a huge operative list today, and there is no time to waste. But what if we just have 1 minute to examine each patient? Let's have a look on the first patient together. This patient, while performing classic abduction, he dislocates it deliberately and then reduces it again. What about the second patient? The second patient, he intendedly dislocates the shoulder posteriorly and then get it back again. The third patient, while I was performing examination of the lateral end of the clavicle, I palpated that the lateral end of the clavicle was a little bit posteriorly displaced. So I asked for a CT, and I found that the CT demonstrated that the clavicle was posteriorly subluxed, not only superiorly. The fourth patient, while performing the examination, I found that all the range of motion of the shoulder coming from scapulothoracic with extreme limitation of the abduction, while the fifth patient had full range of motion. So according to the literature, the first and second patient with Stanmore triangle, they were polar type 3, which was muscle patterning, or what we call AMBRI, what's called the multidirectional instability. And most of the literature, of course, go that this patient needs only physical therapy and rehabilitation and then muscle coordination. And there is no role for surgical treatment in this patient. The third patient turned out to be type 4 local classification and not type 3. After just finding that it was posteriorly displaced. And of course, this mandated open reduction rather than just going for conservative treatment. The fifth patient is a huge pool of the literature talking about the relevance or the whether to go for arthroscopic repair or go for conservative treatment for the asymptomatic rotator cuff tear. We're not talking about this debate here. I just wanted to highlight that clinical examination and proper history taking is really mind shifter and can change your perception to the patient. Each shoulder patient or any orthopedic patient will come complaining of one or multiple of these symptoms: pain, stiffness, swelling, deformity, instability, sensibility, weakness, and loss of function. And I usually like to use the seesaw principle to remember that. Let's imagine shoulder is a seesaw. We have the power, the fulcrum, which is the joint itself, and the lever. we have the engine maybe stuck or maybe squeaky. Of course, to link the symptoms, the weakness would be a problem of the power of the or the liver. The instability would be a problem of the fulcrum. The pain would be a problem of the engine, squeaky engine, or stuck engine like stiffness, deformity, and loss of function. And to examine each of these symptoms, we need to have a fixed protocol we follow. Whatever the protocol you want to follow, there are multiple protocols. Sorry. There are multiple protocols we can follow, but personally, I'd like to use the look, feel, and move, and then special tests principle. Before going into the depth of the examination, we need to know that the examination is a skill. It's like an art or it's like a dance. And to be perfect in the examination or in any skill, you need to try multiple and hundreds of trials to reach the naturalization principle. Here we show the Bloom's taxonomy for any skill acquisition. It passes through 5 steps: through imitation of your mentor, then try to memorize what is going on and to perform it, which is called manipulation. With multiple trials, you will reach precision. With more and more trials, you will reach articulation. And at last, or maybe tons of trials, you will reach that naturalization. It's the same like this. It's like a dance. You need to pay attention for every step you do each time to reach the perfection and the naturalization, like this dancer here. So let's get back to the steps here. First, I'd like to go for stand in front of the patient, have a look for skin, scar, swelling, atrophy, hypertrophy, deformity, and shoulder asymmetry. Then I look at the side and look at the back. Then I approach the patient from the affected side, perform palpation for tenderness, temperature, neurovascular examination. Then I will perform the range of motion, which is passive and active. After that, we will go for the special test, which will be some people just need the abbreviation MESI, M-I-S-I, to remember that: muscle power, impingement, sit, and then instability. But whatever the abbreviation you use, we'll examine the muscle power, droop prosopospinatus, drooping infraspinatus, lift off subscapularis, and hornblower test. Then the impingement test, Mears, Hawkins, O'Brien, and Speed, and then sit the patient and examine the instability. Here is a depiction of how would we approach the patient. First, we will stand in front of the patient, look for skin, scar, swelling, atrophy, hypertrophy, and deformity. Then go for the side of the patient, and then the back of the patient, do the same inspection. Then we will approach to the patient side, perform the feel, then the move, then the special tests. And then we will get the patient sitting down. We will examine the patient by instability tests. Here's an example of the examination. I will let you see. So I start with the sternoclavicular joint, go through the clavicle, acromioclavicular joint, then go directly to the bicipital groove, the coracoid, and then the anterior anterolateral edge of acromion, then go to the greater tuberosity. While I'm in the greater tuberosity, I move passive flexion, pain disappear from not, and then passive extension. Then I will go back to the blade of the scapula, supraspinatus fossa, intraspinatus fossa, and go to the quadrilateral space. Please, while I'm standing in your back, would you try to perform this procedure? Okay, while I'm over there. Okay, I will look at the move now. So start please. I'm looking at the symmetrical motion of the scapula. It was symmetrical. Could you hold your position, please? I will hit my tonometer and put it over here, over the shoulder. So the abduction is almost 170 degrees. So thank you. I would do it active, passively,
So it's almost full range of motion, also by active. I will now examine the internal rotation while I'm here. Could you please put your hand behind your back and elevate as much as you can? So by internal rotation, he can reach the blade of the scapula. Okay, so I will now examine the external rotation. Could you please put your hand like this and then form rotation to it and keep it touching your trunk. Okay, so the external rotation range is about 45 degrees. So I will now proceed with the forward deflection. Please elevate it. My eyes are checking that is no longer increasing. So here's the maximum flexion now. It's small. So the forward flexion range about 170 degrees. So I finished the movement actively, both actively and passively. I will go now for the most power for the rotator cuff. I will start with the supraspinatus. So it's the left side, right? So I will put it in this position and ask you to press forward, please. Okay, the muscle power is fine. I will start with the drop arm side. Will you please get it down? Okay, it's fine now. So I will do now the external rotation resistance test. Could you press the outside? Yes, more pressure, please. My hand is feeling the interference process, so it's fine. I will now examine the teres minor. Could you please external push it back, push my hand. Okay, same. So the teres minor is fine. I can feel it contract as well. Now I will test the subscapularis. I will do the left of test. Could you please hold your hand away from your back? Yes. Could you please resist me? Yes, I feel the subscapularis now, so it's contracted well. In his condition, also I need to examine the deltoid, the rectoralis major, the isthmus dorsi, and the serratus anterior. Could you please perform this position against resist me, please? No, here is the fiber of the deltoid. Could you please resist me? Okay. Could you please resist me? I can feel it. So when you put your hands at your waist and push, I feel the rectoralis major. Could you put your hands on my shoulders and press? I feel the isthmus dorsi. Could you press on the wall, please? Put your hands like this. There is no wing of the scapula. Thank you. Would you come over here, please? So now I will go for the Benjamin muscle side. So I will go with the nearest test internal rotation passively. So please don't help me. Okay, so I do it passively. There is no pain with the near side. There is no pain with the open. Could you please resist me? There is no pain with the O'Brien. Could you please? Because there is no pain with the correct test. I will now do the speed test. Would you resist me for reflection? There is no pain. Would you rotate your forearm? Okay, there is no pain with the speed test. So please lie down here. I now go for the stability. It was okay. Let's assume this side. I will go now with the anterior lower. Could you please relax? I need the muscle to be fully relaxed. Here is the upper coil. I grab the upper part of the humerus. Anteriorly, it was stable, no motion. Posteriorly, there's no motion. Also, I will do the jerk and crank test. I will do the apprehension relocation test. I will perform some movement to your shoulder. If you feel any uncomfortable position, please just tell me immediately. Okay? And my eyes are looking at the space. I will perform external rotation. Okay, so there is some sort of apprehension in his eyes. I will support it back by the relocation. I can do it also in the square position. Okay, it's fine. Do you feel comfortable now? Okay, so I will perform internal rotation again and put it back. At last, I will perform the vascular assessment. Can you please do this way here? Okay, do this. Okay, can you feel this radial nerve, median nerve, ulnar nerve, and then I perform the vital gradient.
So this was a demonstration of the
Dr. Osama B, I know that this is a video recording of the examination, but can we raise the voice of the video, please? Or this is the maximum?
It was the maximum.
It was a maximum. Okay, sir. Thank you so much. Please, go ahead.
Wasn't it clear?
A little bit. Some of the attendees is complaining about the voice is not quite clear. It's not a problem. Thank you so much, sir.
So when we follow these principles, according to the presentation, will come if the patient was coming with weakness. So sit, stand the patient, look, feel, and move. We will find that the patient will have atrophy. We will take the symptoms here: atrophy, asymmetry, active range of motion is affected. According to the muscle affected, maybe job test positive, drooping sign positive, left off or lower, whatever the muscle affected. And based on that, we will then go for the radiological evaluation, which may demonstrate rotator cuff tear, as we see here in this MRI, which will necessitate, of course, arthroscopic repair or whatever the technique. It's not our point here. Or we may find that the muscle is completely wasted due to suprascapular nerve entrapment, which may necessitate arthroscopic decompression of the suprascapular nerve. If the problem was instability, so we will follow the same principle, stand the patient, look, feel, move, then muscle power, impingement, sit, and instability test. We'll find the problem here in the deformity, asymmetry, the motion might be affected, speed and Yerson might be positive, and the apprehension relocation test, of course, would be positive. So on evaluation of the MRI, we may find the Bankard, the Pertus lesion, or head sacs lesion, the bony Bankard, whatever, and then we would manage accordingly by the method of treatment according to whatever the protocol is going to use. Here, they use on track and off track for the management, and they do lethargy or rembrissage according to the situation. If the problem was in the liver, I mean short liver arm, like greater tuberosity malunion, like clavicular shortening, maybe acromioclavicular instability, the patient will also be complaining of weakness. So of course, we'll find a problem in the skin. We'll find asymmetry. We may find a scar of previous operation. We may find deformity or asymmetry. Of course, the range of motion will be affected, especially the active because of the muscle weakness. The job test will be affected. All the impingement signs would be there, and also the major muscles of the shoulder, like the deltoid or pectoralis major, might be affected. In this case here, we have shortening of the clavicle affecting the liver arm of the muscle. We have greater tuberosity malunion, and in this case here, we have greater tuberosity non-union, with the patient completely losing the abduction and external rotation power. And of course, after open reduction and fixation by posterior approach, he restored the abduction range of motion and the external rotation range of motion. What if the engine was stuck, like arthropathy or frozen? Of course, we will find a huge problem in the atrophy, hypertrophy, deformity, and asymmetry. Of course, there will be a widespread tenderness, and both the passive and active range of motion will be affected. Here, the X-ray, of course, is crucial to determine if it's arthropathy or not. Maybe arthropathy, like the left side of the screen, or it may be just a frozen shoulder by taking history and performing examination. Of course, if arthropathy would go through the shoulder arthroplasty, reverse shoulder arthroplasty, and if frozen, we would manage accordingly, maybe by physical surgery or manipulation or arthroscopic release. At last, we have the squeaky engine, the pain. The patient is complaining of impingement. So the range of motion would be fine, the look would be fine, the problem would be in the tenderness, and all the impingement tests like Neer, Hawken, O'Brien, Speed, and Yerson, according to which part is impinged. In this patient, we may go for conservative treatment first, but if persistent, we may need slab repair, we may need bicep stenodesis, so according to the situation. I'm not sure if the voice, Dr. Muhammad told me the voice was not clear enough, so all the videos of examination.
No, the voice is excellent, sir, but in the video a little bit not clear.
On the EOA OrthoTube channel, all the videos of examination are there, and the voice would there be fine. So I think if it's not clear here, you can revise it on the EOA OrthoTube channel. So the take-home message: the diagnostic tools, no matter how advanced, are not a substitute for meticulous, proper history taking and clinical examination. And the second take-home message is that to be on the right side of the screen and to examine the patient this natural, you need to follow the steps hundreds and hundreds of times, like the left side of the screen. So there is no shortcut for perfection. You need to try multiple times to be perfect in examination. Thank you very much.
Thank you so much, Professor Osama Samir Garoor, for this interesting talk. And thank you so much for supplying us with all the videos of clinical examination of all the joints, which is all uploaded on the YouTube channel of the Egyptian Orthopedic Association. Thank you so much, sir.
Thank you very much. Thank you.
Before I introduce the next speaker, I would like to thank my dear friend, Dr. Srinivas Kamphamti from India, for his great assistance in this shoulder specialty day and all over 5 years of medical education online for supplying us with our dear colleagues and our dear professors from India, from UK, from USA, that will give us a great opportunity to get benefit from their extreme knowledge. Our dear speaker will be Dr. Senthilivan Rajajuban from India. His Excellency will speak about cost-effective approach in arthroscopic rotator cuff repair. Thank you so much for being with us, sir. It's a great honor for me. Thank you so much, sir.
So thank you very much for having me, Professor Mohammed Al-Shab and Dr. Srinivas. It's been an extreme honor, to be amongst, elite speakers so many of them. And thank you very much. So my talk is actually on arthroscopic cost effectiveness in the cuff repair. So I am presently working as head of department in shoulder upper limb unit in MAOT International, which is one of the tertiary referral hospital in southern Chennai, South India, and you're all welcome to India. So very important to note is that the cost is a very important part, but it's not more than the quality. So the best way to reduce the cost is to actually have a quality, outcome. But at the same time, we cannot compromise on much of cost, especially in a country like India, which we can echo similar to that of Egypt. The population, about 80% of them live in the not in the metros, and we have a significant problem, especially with the rotator cuffs, where shoulder surgery is expensive, and so it is a significant problem, addressing them. A lot of times we talk about, the integrity of the cuff, but then, affordability of a surgery is a significant factor. So I have to make some disclosures. We have a fund received from what is called as a National Health Hub for Innovative Device Development from the Government of India. So we've developed a device and prototype and also tested and now presently in market. I'm going to talk about the device and also the methodology, how we went about for doing the transosseous cuff repair. So the device system that we use presently, it's called ArthroCuff. It is an arthroscopic transosseous rotator cuff repair system. And as I already mentioned, we've got government funding and we've also developed the process, tested it, the cadaver testing, and also prototyped it. And also now it is presently in significant use amongst a number of shoulder surgeons across India. So how did we go about it? We first of all looked at the problem and we looked at a lot of existing products, whether, we had a group of engineers along with our orthopedic surgeons, and then we looked at existing products and we thought that, first of all, why reinvent the wheel, whether it's possible to just use whatever is available in the market. But unfortunately, we didn't have any system that was already usable, because we know transosseous is a gold standard of repair and it's been done for ages and decades and it provides very good results as an open repair. But then, making that into an arthroscopic method was a significant challenge because we didn't have a reusable instrumentation in India. And the other thing is that, we didn't have any licensed system that was available in India for use. So looking at the problem, then we tied up with a national agency and then along with the engineers, and then we went through multiple revisions and prototyping and cadaveric testing, and then we patented the design process. We know that it has been the transosseous repair has been pioneered by a number of giants before us, and I've had personally interacted with Sumant Krishnan, who is a pioneer of this. He's invented the arthro tunneler, but unfortunately it's not available in use, and also it is a disposable system. Giant needle technique, we know that our own Professor Basim Fliga from Egypt, he's pioneered the giant needle technique, and there are other techniques like the Kuroda technique from Japan. But it is a bit more complex to use, and recently there's been like tensor rods and drill bone which are available. But we went through our own process of actually developing the transosseous repair system, but our principle was simple, where to actually produce a autoclavable system where the surgeon should be able to autoclave the instruments and should be able to reuse them again and again, so that, and it should be like a reproducible technique where even a beginner should be able to do it. So why transosseous? We know that because it does not have any implant, it provides a better biology, in fact, of the repair. And the revision surgery obviously becomes less challenging, and most of important of all, it is cost effective because you just use only sutures for the repair. And there is enough and more clinical evidence to support the use of arthroscopic transosseous repairs with using other systems, and where we know that the anchor repair gives the same clinical results for that of an anchor approach. And also the tendon bone interface motion, when we actually look at them in a transosseous repair, is equivalent to that of double row repair, and it also provides much amount of equivalent pressure distribution across the footprint of the rotator cuff when you compare with the anchor fixation techniques. And also the structural integrity of the transosseous repair is as good as that of a double row repair, and that has been not just biomechanical studies, and we've published our own techniques of comparison with anchors in also the technique has been published in arthroscopy technique as well. So, as I mentioned, there are different systems that are available, and we first used a different model and then we prototyped them, but we ended up with the medial and the lateral, tunnel concept, which is where you have a vertical tunnel and a horizontal tunnel, but then, we had to use a much larger length of the arc, and also the mechanism of capture mechanism was much different than that of existing systems. And the other advantage of this system is that it is a autoclavable system, which means that you can just reuse it again and again. The main feature of this particular system is that it has a screw system, which actually is it is inserted from the horizontal hole, and then it is captured into that of the arc mechanism, and then it actually captures and brings it to the other tunnel. So the instrumentation is very simple, where you have a awl which actually then punctures and makes the pilot hole, and then you have a curved jig which actually goes through the same lateral position. I do them in lateral, but I have a number of colleagues who do them in beach chair position as well, is similar. And you negotiate and get it into the pilot hole, and then you actually have a horizontal drill bit which actually goes in, and it has got a stopper mechanism, so from outside you'd be able to know exactly where it stops. And then the mechanism you can see on the picture is that there's a screw which actually just is on the tip. It actually has a sutures that actually are loaded prior, and then this is actually inserted horizontally into it, and then once you actually capture it, the screw disengages from the capture mechanism, and then the jig actually can be taken away through the same lateral hole, and then you would have a horizontal hole, a vertical hole, and a shuttle suture through which you could actually pass fiber wire or fiber tape, and you can do up to maximum of 3 tunnels, but ideally 2 tunnels, and this can be used for managing most of the tears. So the mechanism is quite simple, as I explained: a vertical tunnel, and then the jig is passed through. The only difference is that we use a slightly lower lateral portal than the normal portal. This helps in because you would have to negotiate the acromion, and then you actually pass a horizontal, drill, and then you would actually pass the mechanism along with the screw mechanism to actually capture it onto the tip. And then what happens is that, as you can see from these pictures, this is a demo model, you can see that it'll actually have a horizontal and a vertical tunnel through which the shuttle mechanism comes through. So we know that this question we get asked: will the bone give way in a very grossly osteoporotic bone? Obviously there is a chance, but the same thing holds good in case of transosseous as well. But the tunneler is designed in such a way it actually captures up to about 2 centimeters. So that means that it captures the maximum amount of bone of the available systems. And we know from CT data that actually, there's good amount of lateral cortical bone, and this helps in actually preventing cutouts. And this is already published in arthroscopy techniques, and it is available so that it can be viewed at any time. But just going through the technique, we use a standard regional block. And then, as I explained, we do a pilot hole to start off with and standard arthroscopy. And then you also make a low lateral portal and insert the jig, and then you actually drill through the lateral aspect to up to that of the pre-stopped part. And so this is the video technique. So this is a standard arthroscopic view, you can see that it's a moderate size tear. And then we look for the repairability as out of a standard process. And then we insert the jig. And then once you actually insert the jig and also put the lateral tunnel, you actually pass the sutures through. And once you get the sutures through, then afterwards, it's the pretty standard process of actually repairing the rotator cuff. And the knots are usually, you can actually place them quite laterally so that you can avoid any impingement. And usually, as long as the repairability of the cuff is good enough, you would be able to get a very good, robust repair. And so we can actually have multiple suture patterns. You can have a simple sutures, you can place them laterally, or in fact, you can do a H pattern or an X pattern, depending upon the, there's no limits as long as you can actually have the tunnels and pass the sutures. And now, as we get more and more experienced, we'll be able to deal with more and more advanced tears. And in fact, we have colleagues who actually also manage even subscap tears through an oblique tunnel. So, and we do notice that the patients actually have lesser pain, and we can't explain the phenomenon, but we actually compared them. But, in the shorter term, they do have less pain compared to that of an anchor-based repair. And we follow them with MRIs at, a year's time, and we can see that the tunnels are actually completely resolved. You can see there is very little bone damage and the cuff healing nicely. And in fact, if at all the patient needs revision, you've got good bone stock there even to revise them. So we do have trained up to about like 150 surgeons so far, and it's been a slow journey because of there's not much of industry funding. This has been a lot of effort from the government as well as the individual surgeons, but we hold a lot of cadaver labs. It's been certified, and a lot of medical colleges, and now with more and more adaptability, it's been certified. So we do provide the instrumentation set to it's as a peer-to-peer model. So in fact, we have actually gone and also done more advanced procedures like even massive tears. So when we actually the lower trapezius transfer, we just published that we can in a massive tear as well use a the transosseous system. And for example, this patient, a 62-year-old male patient with a chronic massive retracted tear, as you can see from the MRI pictures. And so the patient is placed in a lateral decapitated position, and the area is actually prepared as per standard, and you can see that's a significantly large cuff tear. But the difference is that we also clear the subdeltoid region because you would want to see the lateral aspect of the tunnel. And then we actually insert the awl to begin with from a superior position. And then from the low lateral portal, we insert the jig onto that of the pilot hole. And you can see from as and when we insert snugly onto the lateral aspect, then we actually drill through the lateral aspect to create the lateral hole of the, or to complete the tunnels. And then you would actually pass the screw mechanism along with I use PDS sutures, and then these are shuttled through from the lateral to that of the superior portals. And then once you have them, then each tunnel can accommodate up to 3, sometimes 4, and we can use a combination of fiber tape or fiber wires. And having a different colors usually help because then you can identify them. And in this particular case, we have used some of this, one of the sutures to actually do a partial repair of the infraspinatus here. And then we leave and make that anterior tunnel as well. So 2 tunnels with sutures are already there. And then subsequently, we have actually, we use a peroneus graft for this particular patient to use it as a tendon transfer method. So this is just the anterior tunnel being done now. And the same process is repeated. Then we actually shuttle the sutures and then make sure that you actually have the sutures in position before the tendon can be actually inserted into the subacromial space. As I previously explained, then we actually go on to expose the posterior aspect and look out for the lower trapezius and then the peroneus graft is actually inserted. And then what you do is that you have the free sutures here as a loop, and then this loop is then used to actually pull through into the subacromial space, into the tunnel. So this is the peroneal tendon harvest. And then because allograft is not freely available in India, so we have to adapt it to use the peroneal graft. And you can see that the lower trapezius muscle is identified, and then stay sutures are done. And then we actually pulver-taft them through here. And then through the tunnels which are already having the sutures, we pass the tendon and then actually pull through them and actually use them to suture them, so that it actually forms the a robust fixation through the tunnels, so you can actually tie them. And then once these are tied on to that of the bone, then you actually then retract them and then actually put stitches into the lower trapezius in the abductor and external rotated position. So these are the arthroscopic view pictures, and you can use them, the rest of the sutures, to do any additional sutures if you want to complete it by actually weaving them through the tendon in the subacromial space as well. So, and then, once you have them secured into that of the subacromial space through the tunnels, then you would actually, suture them to the lower trapezius through pulver-taft technique, and then that completes the lower trapezius transfer. So, going on from actually simple to moderate tears to massive repairs. So we've actually moved on to even do massive repairs. So this is a significant step for us, not only addressing the cost, but also in terms of quality. So we don't no longer restrict them to people who can't afford. It is done for insurance patients. It is also done for patients who can afford. So it is a significant step in terms of, like, the learning curve is slightly more than that of an anchor-based repair, but the possibilities are endless. So effectively, it's a transosseous implantless cost-effective system. And I'd like to thank my colleagues, Dr. Nehru, who is my colleague orthopedic surgeon, and our engineer who stayed along, and the funding agencies of the government who has helped in actually making this as a concept. Thank you very much.
Thank you so much, sir, for this very interesting presentation. If we have any questions. I think we have no questions. Thank you so much, sir, for being with us. It's a great honor. Thank you so much.
Thank you very much.
Thank you. Our next speaker will be Dr. Radhakanth Pandey from UK. He will speak about management of massive rotator cuff tear. Thank you so much, sir, for being with us.
Thank you. Can you hear me?
Yes, sir. I can hear you.
Yeah. Sorry, I didn't get your email, so I'm using Srinivas's email. So
thank you so much.
My name's there. So
thank you so much, and many thanks to Dr. Srinivas for his great work with us. Thank you for both, sir.
So shall I share my screen now?
Yes, please, sir.
Okay, can you see my screen?
Yes, Mr. Pandey, yes, sir.
Okay, so I'll be talking about management of massive irreparable rotator cuff tears. So I'm Mr. Pandey. I'm a consultant in trauma orthopedics at University Hospitals, Leicester in UK. We have a lot of Egyptian consultants also here. So here we go. So irreparable cuff tear, but not all cuff tears are irreparable, but almost 30% of full thickness rotator cuff can be classified as irreparable due to massive size, retraction, muscle atrophy. So irreparable massive cuff tears can lead to significant disability from pain and possibly pseudoparalysis. Especially if a patient is young, it's quite disabling. And we are seeing people in their 40s and 50s coming with massive cuff tears, which cannot be repaired by either arthroscopically or open. So how do you deal with such a complex issue? So this is a massive cuff tear with pseudoparalysis. You can see the gentleman is hardly able to lift his shoulder fully. This is a massive cuff tear MRI. The edge of the cuff is almost to the glenoid. it'll be very difficult to repair this by conventional means. So what are the options available for massive irreparable cuff tears? So first option is targeted rehab. You'll be surprised a lot of especially the elderly people, can be rehabbed to a reasonable function without any surgery. But this is generally for elderly people, but other youngsters also should have a good rehab before you think of any major surgical intervention. People used to do debridement and subacromial decompression. I think it's pretty useless to do them because the outcome is very poor or very short-lived. Then there is tendon transfers, and I'm sure you heard something about tendon transfer, and I think the next talk is about tendon transfers, so I will not go into details, but that's a good option to treat these complex problems. Partial repair or margin convergence. So even if you do a partial repair in this major large cuff tears, things can be made better. I will come to all these individually in my presentation slowly. So this is a targeted rehab, and if you basically you are ignoring the cuff and re-educating the deltoid, pec major, trapezius, and subscap. And there is a very nice regime which is widely used called the Torbay Hospital regime by Ainsworth. You can Google it and you can get it in your hospital and use this for massive irreparable cuff tear. And a lot of patients can get better because surgically you may not be able to repair the rotator cuff. This is a very good option. So I would highly recommend this physiotherapy regime, which you can find on Google. Tendon transfer, I think the speaker next to me will be talking about tendon transfer. We like inferior trapezius transfers, extend it with another tendon or even an allograft, and then use it as a cuff, use it to attach to the cuff. But of course, my talk will not be dealing with the tendon transfer. The next one will. Partial repair. I was telling you that you could do a partial margin convergence. Here's a massive cuff tear, and it's been partially repaired. So what has happened is the posterior cuff and the anterior cuff has all been brought up, and that causes the head to depress down, and this patient can be rehabbed and can have a reasonable good function. There is enough literature to say even partial repair is better than debridement or leaving things alone. So if you can't do anything and you think you can do a partial repair or a margin convergence, I would strongly advise you to do it. People used to do this balloon arthroplasty in which you insert a balloon in the subacromial space that depresses the head down and hopefully rehabs the patient. This is largely given up because of complication, and it's a very expensive procedure. So in UK, we don't do this anymore because of complications and expensive procedure, and the results are not so good. This is obviously a fantastic treatment option, reverse shoulder arthroplasty, especially in the elderly. When you have a large cuff tear like here, you can't repair it. Even if you do something, the chances of it failing is very high, especially patients in, say, over 70, 75. A reverse shoulder is perfect as it sort of bypasses the use of rotator cuff and uses the deltoid by changing the biomechanics by which the shoulder functions, and the deltoid uses the deltoid to give a very good function in the shoulder. So we have used this extensively. It's used extensively world over, but this is generally done for elderly people. But nowadays the definition of elderly is very, very woolly, and people are doing them in younger patients too. This is something which we do quite often. The biceps tendon is intact and it's quite thickened, hypertrophic because the cuff is gone. And we use this biceps tendon. You can open it like a fan or use it just as a natural patch. And I'll show you, that's, if you see, there's a big biceps tendon in a large cuff tear. So we could be ashamed to just waste this biceps tendon. So what a lot of people do is use the biceps tendon, you tenotomize it, and tenodize the distal bit, and this tendon you can incorporate into the rotator cuff. So you can attach the subscap in the front and infraspinatus at the back, and this acts as a depressor and fills the gap. You can even spread it around and cover the gap left in a large to massive cuff tear. And people have shown reasonable results. So it's a naturally occurring graft. It's there, and you can use it to fill the gap if you can't fully repair the rotator cuff. Now, superior capsular reconstruction, I'm sure you've heard about it by Dr. Mihata from Japan. He's a pioneer in the superior capsular reconstruction. What happens when you have a massive cuff tear is the humeral head escapes, because every time you try to abduct the shoulder, the deltoid contracts and lifts it up. Normally, the cuff would depress it down, but there is no cuff, so it goes off and hits the acromion and causes erosion of the acromion. So what the superior capsular reconstruction does is they use tensor-fascial autograft and attach it to the glenoid here and the greater tuberosity here. So this graft depresses the humeral head so that the deltoid can lift the shoulder. It has had reasonable results. That's the sort of schematic representation. Big gap, and this has been put on top the glenoid here and greater tuberosity here. So theoretically, it improves function by recentering the humeral head and improving glenohumeral kinematics. It restores the functional fulcrum, and it allows deltoid and remaining cuff to function more effectively. But recently, there has been some doubts raised about its efficacy. So it works in some people's hand and doesn't work in some people's hand. So one has to be careful. You can do it arthroscopically. It's best done arthroscopically. You can do it open too. But as I said, the results are becoming a bit questionable in the long run, especially after 2 to 3 years, but it's still widely used. This is what I'm going to concentrate today on, the patches. Now, if you have a large cuff defect which you can't repair, there are many patches being used to bridge the gap. I'm not talking of augmenting after you repaired the cuff. I'm talking of cuff which you cannot repair at all to bridge the gap. Now, there are many interposition patches, allograft, which is what we use. It's called the graft jacket. It's a human dermal graft. You can use autografts like the tensor fascial lata, which hasn't worked very well. Then there are other grafts like the porcine graft, and there are synthetic grafts. So we use human dermal allograft bridging for massively repairable cuff tear. So generally, that's the way we do it. But instead of a superior capsular reconstruction where the medial bit of the graft is attached to the glenoid, we attach it to the residual cuff itself. And there's enormous amount of literature on graft jacket. It's been used arthroscopically. And we are in Leicester have published extensively, published in big journals. We have done over 500 patients with almost 10-year follow-up. So this is a long-term follow-up, and if it works very well. Why is it better? I think it acts as a biological scaffolding, and there is still migration into the allograft. And as you can see, the histology here, there is a bit of original tissue and bit of the graft jacket, and they are growing into each other. So it incorporates into native cuff tissue as neotendon, and it also restores the force couple and restores a stable function. So I think it's not just a physical barrier, but a biological scaffold in which cells can grow. We have done a study in which we compared a partial repair with graft jacket, and we found if you add a graft jacket interposition, the results are far, far better. The constant score is also far, far better. So this is a case, large defect. The biceps tendon is quite hypertrophy. One could use this tendon, but since the defect is so big, we decided to use graft jacket, and we just tenodesed the biceps tendon and took out the rest. So this is how a graft jacket looks like. It's quite an expensive. It's a dermal. It's a tissue from human beings, and it's there are various ways it is harvested and preserved. And this is how it looks like once you have attached it. So attached medially over the residual cuff, and it's attached laterally either with intraosseous sutures or with anchors, and attached in the front to subscap and whatever residual tissue there is at the back. Now I'll show you this lady who is pre-op, and you can see she's got pseudo paralysis on one side, hardly any forward elevation, very little abduction with some pain. Now, she underwent a graft jacket bridging repair. She had a massive cuff tear, and this is after 2 years. She has full abduction, full external rotation, a full forward elevation. Obviously, this is our best results, and since it's a conference, I'm presenting my best result. Not everybody achieves the same, but all of them do better. Now, that's the lady. She had a massive cuff tear, hardly any rotator cuff left. This is 2 years. This is the MRI scan after a graft jacket. You can see the empty space here, and now you can see the tissue. This is not just the graft jacket, but it's a neo tendon where some integration has occurred with the native tissue. So what to expect in these massive cuff tears where we can't do any repair? So there are many options: tendon transfers, reverse shoulders in elderly. Graft jacket is a good method because we can use them in young patients too. In fact, we use them in young patients over tendon transfers. You can do a partial repair, or you can use a biceps tendon to bridge the gap. But you will not get a normal shoulder. You'll get a better shoulder. But it is important to give these patients a better shoulder, which can help them with day-to-day function and improve their pain. Pain is definitely much better, and we found that even when we use the graft jacket. They get they do get some increase in the power, but not as well as it was. But even if you do a reverse shoulder, you have reasonable power, but not as good as it was with the cuff. So these are the few of my thoughts about how to manage massive irreparable cuff tear, which is a very difficult problem, especially in young people, where you can't do a reverse shoulder, and tendon transfer is a complex operation and requires a lot of skill and rehabilitation. So we find that doing a graft jacket allograft has been very helpful. Thank you.
Thank you so much, Mr. Bandi, for this interesting presentation. I think we have no questions. Thank you so much, sir. Thank you, sir, for being with us. Thank you so much, sir. Our next speaker will be, thank you, sir. Our next speaker will be Professor Amr Kandil from Menofia University, Egypt. Professor Amr will speak about middle trapezius tendon transfer for irreparable rotator cuff tear. Dr. Amr, please.
Yes, sir. Okay, it's okay?
Yes, sir. Yes, sir.
First of all, much thanks to Dr. Muhammad Gamal Asha for his invitation to join the Shoulder Specialty Day of Panama University and to give this talk on medial trapezius tendon transfer for irreparable rotator cuff tears. Uh, Currently, among the shoulder surgeons, there is a wide agreement on the criteria of repairable cuff tears. These criteria might include massive retracted tears with profound fatty infiltration, marked decrease in muscle bulk, in addition to decreased acromial distance and poor tendon quality on intraoperative assessment. On the other hand, there is still much debate among the shoulder surgeons regarding the management options of a repairable cuff. However, these management options can be categorized into three groups. The first group is replacement arthroplasty, namely the reverse total shoulder replacement. However, there are still concerns on the inconsistent post-operative range of motion, in addition to the factors or drawbacks related to the cost and the technically demanding revision management. Another option might be repair, especially the partial to the cuff repair, which might, according to Stephen Burkhardt, revealed or yield favorable post-operative outcomes in terms of pain. However, there is still some debate on the inconsistent post-operative range of motion and function. Another option might be reconstruction, including the superior capsule reconstruction and tendon transfer. As regards superior capsule reconstruction, there are different techniques which have been described for reconstructing the superior glenohumeral capsule, such with the use of fascia lata, dermal allograft, or long head of the biceps. The main advantage of superior capsule reconstruction is its biomechanical role in restraining the superior migration of the humeral head with subsequent improvement in the post-operative pain scores. However, there is still this may not be the case for the range of motion and function, and this might be mostly explained with its static nature. On the other hand, tendon transfer, due to its dynamic nature, has gained increasing interest among the shoulder surgeons, and historically the tendon transfer or the techniques of tendon transfers has evolved over the just a few decades. First of all, Dr. Kirsten Gerbert has described the transfer of the latissimus dorsi for the management of the repairable posterior superior to the cuff tears, reporting favorable outcomes. However, the main concern of this transfer might be the long-term sustainability of the outcomes due to the inability of the latissimus dorsi to recentralize the humeral head over the glenoid. Currently, the trapezius muscle has gained increasing interest among the shoulder surgeons, and over the past decade, different authors have investigated the transfer of a part of the trapezius for reproduction of the irreparable total cuff, reporting debatable conclusions. For example, Gutalia has described the transfer of the upper trapezius for dynamic reproduction of the subscapularis. However, the results were unfavorable, and he has discontinued his study after about 20 patients. On the other hand, Basim Hassan has described the transfer of the lower trapezius for dynamic reproduction of the infraspinatus, reporting favorable outcomes in terms of restoration of the range of external rotation. This conclusion was partly explained with the collinear force vector of the lower trapezius with the infraspinatus. However, preoperative forward flexion of less than 80 degrees remained a contraindication or poor prognostic factor for this transfer due to the inability of the lower trapezius to reconstitute the supraspinatus function. Due to its biomechanical, anatomic, and electrophysiological features, middle trapezius transfer might have the potential for dynamic reproduction of the supraspinatus. Based on these formal remarks, we have described and published a technique of the middle trapezius tendon transfer for the management of irreparable posterior superior tooth cuff tears. This technique or transfer is performed by two approaches, the McKenzie and the medial scapular approach. First, we through the skin incision about 6 up to 7 centimeters over the medial side of scapular spine. The medial portion of the medial trapezius is identified and harvested from the scapular spine and released from the overlying fascia. Then the released medial trapezius is tested for excursion. Afterwards, a fashion sheet of hamstring tendon is passed via a subtrapezius subacromial corridor. On the scapulohumeral side, the sheet is sutured to the footprint of the rotator cuff and to the reverted cuff, while on the scapular side, the tendon sheet is sutured to the middle trapezius, and the whole construct is then evaluated under dynamic evaluation. What about the clinical validation of this transfer? In order to validate the transfer of the middle trapezius, we have conducted and published a clinical study in which the patients were allocated into two different groups. The first group were managed, patients in the first group were managed with two-layer tendon construct, including the first layer of in situ superior capsular reconstruction and the second layer of partial tendon cuff repair, while patients in the second group were managed with three-layer tendon reconstruction, including first layer of superior capsular reconstruction, a second layer of partial tendon cuff repair, in addition to a third layer of middle trapezius tendon transfer. Two-year post-operative intra-group comparison revealed significantly higher or better outcomes in group B in terms of pain, range of motion, and function, as in this case of male patient of 55 years old with irreparable posterior rotator cuff tear. The patient was managed with middle trapezius tendon transfer. 5 months post-operative evaluation revealed significant improvement in outcome measurements, especially range of motion and function. Such favorable outcomes of the group B or patients managed with three-layer tendon reconstruct might be explained with the third layer or the middle trapezius tendon transfer, which might offer a number of biomechanical advantages, including the dynamic reduction of the cerebrospinous function via its collinear first vector, close anatomic features, phasic recruitment during shoulder elevation, and the convenient room of supraspinatus fossa for the gliding motion of the reconstruct. This dynamic reduction of supraspinatus function by the transferred middle trapezius might be supported with the in vivo dynamic reproduction might be supported by a number of remarks, like the in vivo dynamic provocation of the tendon reconstruct, and also might be supported with the post-operative radiological evaluation, which might reveal the increased muscle bulk and acromial-humeral distance, in addition to low intensity signal of the transferred tendon reconstruct on post-operative MRI in comparison with the pre-operative one. This dynamic reproduction of the supraspinatus function offered with the middle trapezius tendon transfer in conjunction with other different static and dynamic mechanisms of the three-layer tendon reconstruct as a whole might have the chance to recentralize the humeral head over the glenoid, thus giving the chance for stable fulcrum with subsequent better situation for the deltoid function, leading to much or significant improvement in post-operative range of motion. Another advantage might be the biology, as the middle enriched vasculature of the transferred middle trapezius might enhance the local biology for healing of the tendon reconstruct. Another advantage might be the recruitment of the transferred middle trapezius during shoulder elevation allows the accelerated post-operative rehabilitation with reduced risk of subtrapezius subacromial scarring. Finally, the technical advantage of middle trapezius tendon transfer might include the reducibility, simplicity, and safety, in addition to the visibility of the arthroscopic modality. However, the main advantage of middle trapezius tendon transfer might be its clinical versatility, which might be shown via under different clinical situations as pseudoparalysis, as in this patient of 45 years old with pseudoparalysis of the right shoulder on top of irreparable rotator cuff tear. The patient was managed with a three-layer tendon reconstruct, including superior capsular reconstruction, partial rotator cuff repair, in addition to middle trapezius tendon transfer. 4 months post-operative evaluation revealed significant improvement in post-operative range of motion and function. Another indication or situation for middle trapezius tendon strain might be revision management following failed rotator cuff repair, as in this case of male patient of 55 years old with massive retracted rotator cuff tear. The patient was managed with mini open rotator cuff repair. However, 9 months post-repair evaluation, the evaluation revealed revealed that the patient still has pseudoparalysis in spite of the radiological evidence of the healing of the repaired cuff. In addition, evaluation via arthroscopy revealed full healing of the repaired cuff. So the patient was managed with middle trapezius tendon transfer using a sheet of hamstring tendon to lengthen the middle trapezius to the footprint of the rotator cuff. 4 months post-operative evaluation revealed significant improvement in outcomes of motion, especially pain, range of motion, and function. Another situation or a case might be rotator cuff repair, as in this case of a male patient of 58 years old with a history of rotator cuff repair 9 months before presentation to our institution. The patient was managed with 3-layer tendon reconstruct, including the middle trapezius tendon transfer. 4 months post-operative evaluation revealed significant improvement in outcome measurements, especially pain and function. The versatility of middle trapezius tendon transfer might be further shown in more difficult situations, as in this case of male patient of 58 years old with massive retracted rotator cuff tear on the top of an incidence of glenohumeral dislocation. The patient was mismanaged at another institution with arthroscopic Bankert repair. So by the time of presentation to our institution, the patient has about 10 times of frank recurrent anterior glenohumeral dislocation on top of irreparable rotator cuff tear. So the patient was managed with subscap repair, in addition to exalt technique in which the long head of the biceps is detached and via a subpectoral corridor to be passed through a window within the subscap to be sutured over itself in order to offer more or less a dynamic sling of the long head of the biceps to increase the anterior glenohumeral stability. Then the patient was managed with partial rotator cuff tear and eventually with middle trapezius tendon transfer. 8-week post-operative evaluation reveals significant improvement in the range of motion of the operated shoulder, in addition to effective restabilization of the glenohumeral joint even under dynamic provocation. دكتور محمد يعني
عمرو بيه ريشير تاني يا فندم.
ماشي. شير يا دكتور؟ دكتور محمد شير؟
لسه يا فندم.
دكتور محمد.
دكتور محمد بيه.
دكتور عمرو لسه شغال ولا حضرتك عاوزني انا اعمل شير؟
لا لسه بيتراي يا فندم ان هو سعادتك
انا مع حضرتك.
حصل تكنيكال بروبلم بس.
Yes, take his time. He take his time.
Thank you sir. You have shared it دكتور عمرو؟
شير دلوقتي؟
هو شير السكرين بتاع البرزنتيشنز different presentations عندك. Yes full screen sir. Yes, sir.
So, sorry for this technical error. So, 8-week post-operative evaluation of this patient revealed significant improvement in active range of motion with effective restabilization of the glenohumeral joint even under dynamic provocation. Another case is a female patient of 55 years old with about 10 times of recurrent glenohumeral dislocation within very short time, maybe 4 months, on top of a repairable rotator cuff tear. So the patient was managed with exalt technique of biceps routing in addition to middle trapezius tendon transfer. 4 months post-operative evaluation revealed significant improvement in active range of motion with dynamic, with restabilization of the glenohumeral joint, even dynamic provocation.
هو the same technical problem في نفس السلايد يا فندم.
طب انا هسكيب السلايد دي.
سكيب السلايد يا فندم.
ماشي. Okay, shared.
Shared.
Muhammad?
Yes.
Okay. So another question might be, what about the biomechanical validation of this transfer? According to a recent publication in the Journal of Shoulder and Elbow Surgery, a group of American and Korean surgeons have, from Pasadena, California, have investigated the transfer of the medial portion of the middle trapezius for dynamic reproduction of supraspinatus function, and concluding that the transfer of the middle trapezius can have a role in restraining severe migration of the humeral head with subsequent decrease in the subacromial contact pressure. So as according to this biomechanical study, the transfer of the middle trapezius might be validated as a management option for irreparable rotator cuff tears. What about the technical limitations? This technique might have some limitations, especially those related to the autograft, like the time consuming for harvesting the hamstring tendon, in addition to technical setup, patient positioning, and such technical limitation represented a drive to describe and publish a technical modification of middle trapezius tendon transfer, which might be named as a biceps-based 3-layer rotator cuff reconstruction, in which the long head of biceps can be used as a local graft for in situ superior capsular reconstruction, anchorage structure for partial rotator cuff repair, and as interposition graft as alternate to hamstring tendon autograft to lengthen the transferred middle trapezius to the rotator cuff footprint. As in this case of male patient of 55 years old with irreparable rotator cuff tear and pseudoparalysis might be for 1 year. The patient was managed with biceps-based 3-layer reconstruction, in which the long head of the biceps was identified in the subpectoral region, suture tagged with non-absorbable sutures. Then the tendon distal to the sutures was reattached to the lower border of the big major for soft tissue tenodesis. Then the proximal part of the long head of the biceps was retrieved from the subpectoral region to the subacromial space for reconstructing the superior capsule. In this, for reconstructing the superior capsule, the trough was created in over the greater tuberosity. Then the retrieved long headed biceps was sutured into this trough using non-absorbable sutures for reconstructing the superior capsule. This was followed with the reconstruction of second layer of partial rotator cuff repair. Then the third layer was reconstructed, in which the tendon of the middle trapezius was identified and harvested. Then the tendon of the long head of the biceps distal to the attachment of the superior capsule was retrieved from the subacromial space to the scapular side, where on the humeral side the tendon was reattached or sutured again to the cuff and to superior capsule, and on the scapular side it was sutured to the released middle trapezius. 8-week post-operative evaluation revealed significant improvement in active range of motion of the shoulder and effective restabilization of the glenohumeral humeral joint even under dynamic provocation. What about the future directions of this transfer? Since we have described this technique, it has received great interest from different surgeons, and different publications have shown its biomechanical and clinical effectiveness. And the next step, for this transfer, it might be coupled with anatomic total shoulder, so the paradigm might be shifted away from the reverse total shoulder towards concurrent anatomic total shoulder, combined or coupled with middle trapezius tendon transfer for management of certain situations in young active population, especially with regard to advanced stages of rotator cuff arthropathy, failed rotator cuff repair, and neglected 3 and 4 part fracture dislocation of the shoulder. To conclude, middle trapezius tendon transfer it is a recent technique. However, it can yield favorable post-operative outcomes, especially young active male patients, intact and repaired subscap and infraspinatus, active teres minor, and with strict commitment of patient to physiotherapy. However, further biomechanical and longer-term cohort clinical studies are still needed to validate the outcomes of the middle trapezius tendon transfer. Regarding online data availability, the currently reported techniques and outcomes are now available online. Much thanks.
Thank you so much, Professor Amr, for presenting this novel technique in management of rotator cuff tear. Thank you so much. If we have any questions to Professor Amr and Dil, I think we have no questions. Thank you so much, sir.
Thank you. Thank you. Sorry for the technical error.
Thank you so much. No, it's not a problem, sir. Thank you so much, sir. Our next speaker will be Professor Muhammad Abdurraouf. Professor Muhammad is the head of anesthesia and pain management department in Cairo University. Professor Muhammad will speak about a very interesting talk, shoulder analgesia from modern techniques and back to acupuncture. Thank you so much for being with us, sir.
Thank you, Professor Dr. Muhammad Al-Ashhab. Please give me this possibility to share my slide screen.
You have the possibility, sir.
No, it's written to have another host.
Just one moment, sir. Just one moment.
You can share now, Professor Muhammad.
Okay.
Thank you, Dr. Michael. Thank you. I was just calling you. Thank you so much. Yes, sir.
So yes. First, I would like to thank Professor Dr. Muhammad Al-Ashhab, the Dean of Bana University, and an eminent professor of orthopedic surgery, and I will try to cover shoulder analgesia in the following 20 minutes. I'll try to cover it in the following 5 points. My department is the Department of Anesthesia, Surgical Intensive Care and Pain Management. So
sir, full screen, please, sir. Full screen, please.
Okay. So we might see the patient. We might see the patient in the intraoperative period, or something happened.
No, it's shared, sir. It's shared.
but it's not seen on my.
It's not present on your screen.
Yes.
You
I don't
can
know.
stop share and
Stop share and
reshare.
reshare, Dr. Muhammad.
I have to stop share.
Yes, stop share and reshare again.
Is it okay?
Yes, yes, sir.
Okay. So I might see the patient in the intraoperative period for intraoperative analgesia or in the chronic pain clinic for chronic pain management. We have one of 5 modalities to treat our patients. Either injections, here we see the suprascapular nerve injection in the suprascapular notch. The second part that we do invasive radiofrequency. And in this patient, we see bilateral suprascapular nerve radiofrequency, and we are using the pulse dose. And in the other video, we see supraspinous nerve motor stimulation. So we see the contractions of supraspinatus and infraspinatus. As you hear, it is a motor stimulation, not a radiofrequency. So we have 5 buttons, sensory and motor are diagnostic. And once you do sensory or motor, patient says, yes, this is the exact site of pain. We can do destructive lesion. Usually we do it in the knee for genicular denervation, but not in the shoulder. Or we do neuromodulation. Using pulsed dose or pulsed radiofrequency. The third modality is using the non-invasive cap energy radiofrequency, which is a Spanish technology. We have 3 probes that can help of us. A capacitive probe with this big size. A resistive probe can work on the hard tissues like bones and tendons and ligaments. And a capacitive plate that can work on soft tissues like muscles, like nerves, and like blood vessels. And I'm saying cap energy because this machine is very well advanced. They have a vaginal probe, external urethral probe, dental probe, and the panty probe that can be used in our pain clinic in chronic pelvic pain and in urinary incontinence in female. The fourth modality is acupuncture. It is a technique thousands of years ago, and being an Egyptian doctor, our Egyptian patient don't accept inserting a lot of needles for repeated sessions. For that, I use a modified acupuncture technique. I use the probe of cap energy machine instead of using the acupuncture needles. So these are the 5 modalities that can help my patient. In the intraoperative period, either I make the patient fully awake and just give him a nerve block or give general anesthesia with analgesia. Personally, I prefer this technique. Why? Because the beach chair position with the head and neck support with arm anesthesia that might happen from trickling of local anesthetics from interscalene groove to supraclaviria, genitalia affection in the men, all of this with difficult intubation if needed, difficult CPR, as well as sometimes the surgeon change his entry point. Again, the draping of the patient and presence of irrigation fluid, which if spoiled over area not anesthetized, might annoy the patient. For that reason, I don't prefer a fully awake patient, although some cases I don't like that. How we have 4 options. The interscalene block, where we put our local anesthetic in the interscalene groove between scalenus medius and anterior. And here we have a relation to 3 important nerves, all arising from the roots of the brachial plexus, thoracodorsal nerve, and nerve serratus anterior on the lateral aspect within the scalenus medius muscle, and the more important, the phrenic nerve on the medial side of the scalenus anterior. And a lot of publications showed injury of the phrenic nerve during the interscalene brachial plexus block. So we should be very cautious to avoid the injury of the phrenic nerve supplying the diaphragm. The second part is shoulder block. We do a combination of suprascapular and circumflex or axillary nerve block. So we are covering about 98 to 99% So we have 1 to 2% of the sensory innervation of shoulder is not anesthetized. So you have to inform your patient, inform your surgeon, and you need a very cooperative patient and surgeon. And if patient feel any discomfort, this should be supplemented by the surgeon with local infiltration. The third technique, which is growing technique, the pinch block, where we block the terminal branches that supplying the shoulder joint. We put the ultrasound probe in this vertical view and allow the patient to externally rotate the arm. We see the deltoid muscle and subscapularis muscle. We go in plane, seeing the whole needle, and inject our local anesthetic in the plane between deltoid and subscapularis. It's very effective for shoulder dislocation, for shoulder manipulation, and even for shoulder surgery. External rotation done by the patient is painful, so now they are trying to do it in a neutral position. The final approach is local infiltration of the portal site of your needle, and I advise my surgeons to do infiltration before needle entrance with lidocaine, and at the end of surgery, re-inject it with bupivacaine elongated. So these are the 4 modalities that can help us intraoperatively, and intraoperative analgesia is more important because it will minimize or even prevent post-operative stormy shoulder pain. When we are talking about chronic shoulder pain, the shoulder is formed by nerves, muscles, joints, and bursa, and any of them can cause pain. And here I would like to highlight that ultrasound examination of the shoulder by a professional radiologist with ultrasound is more superior than MRI because it is dynamic, not static. These photos show everything about the shoulder. So if we are talking of the nerves, we have 7 nerves, and these 7 nerves are the suprascapular, axillary, lateral pectoral, upper, lower, and middle subscapular, and musculocutaneous. And we can block them, and lateral pectoral nerve usually blocked by PEC1 and PEC2. Concerning suprascapular nerve, we put an ultrasound probe over the spine of the scapula. We use the spine of the scapula, the suprascapular ligament, the suprascapular artery. Sometimes we don't see the nerve, and we inject just lateral to the pulsation of the artery. It's a very effective and very easy block. If we would like to do a radio frequency to such nerve, as I told you, we can do motor stimulation if we feel that muscle weakness is part of the pathology, or we can do radio frequency or invasive radio frequency for neuromodulation. Here with radio frequency, we don't see the muscle contractions, but our temperature is 41, 42. See, it is not a destructive lesion, it is a neuromodulation. And these are the 5 buttons that can help us. The axillary nerve present, or the circumflex nerve, around the neck of the scapula, and this nerve in the quadrangular space, we put our ultrasound probe transversely and go a little bit medial, so we'll see the neck of the humerus, the suprascapular, the circumflex artery, and the circumflex nerve, and go with the needle from lateral to medial approach, doing either injection or radio frequency. Now we are talking about lateral pectoral nerve. We have here on the chest wall a 3, 4, and 5th rib, pectoralis minor covered by pectoralis major, and the lateral pectoral nerve can be blocked in between the 2 muscles, it's PEC1, or underneath the pectoralis minor, it's PEC2, and here is a fantastic PEC1 block, the local anesthetics separating pectoralis major from pectoralis minor. And now we can use the non-invasive radio frequency. If you put it here, it's a capacitive, it works on the suprascapular nerve at temperature 37 degrees, or a bigger one, and we can do sympathetic denervation. This is an addition that cannot be done invasively for shoulder patients. The sympathetic supply of the shoulder or of the upper limb coming from segments of the spinal cord from T2 to T9, and the most important ganglia are T3 sympathetic ganglia and T2 sympathetic ganglia and T4 in anomalies of Kunt. Both these ganglia are present on the lateral aspect. So if you are putting this plate on the lateral aspect of the axilla and the passive plate on the opposite axilla, we are neuromodulating the sympathetic ganglia, thoracic sympathetic ganglia responsible for shoulder pain. Here, another addition, we can work here on C5 and C6 while they are exiting from intervertebral foramina, and shoulder is supplied by C5 and 6. So we can neuromodulate this nerve at that area. And clinically, when I put my hands over the transverse process, when I find tenderness, definitely the exit foramina adds to the pathology in the shoulder pain. Now we are talking about the muscles. The same picture, we have 12 muscles. The most important is the four rotator cuff, supraspinatus, infraspinatus, tetraspinatus, and subscapularis, and all here are inserted in the bicipital groove with the tendon of biceps. So if we are working on these hard tendons with a resistive probe of non-invasive cap energy, it will help. These are the muscles with their nerve supply, adding to them the biceps, which is a very common sharing in the pathology for shoulder pain. So we can work, as I said to you, with the resistive probe in this area, and our patient like that, we put the resistive probe. It has a very strong anti-inflammatory and helps in treating such pain. We can work on the muscles itself. Muscle is soft, you are using a capacitive probe on the supraspinatus, infraspinatus, or even laterally on the deltoid muscle that might share for the pathology of pain. Joints, we have mainly two joints. The glenohumeral joint, this is its nerve supply, and here we see the glenohumeral joint. So the second joint is the acromioclavicular joint, and the acromioclavicular joint is its nerve supply. If we do ultrasound, we will see the acromion and the clavicle, and we can go with the needle and inject the joint, or we can put our resistive non-invasive probe. It has a strong anti-inflammatory effect. So I can put the probe on the glenohumeral joint, or I can put it on acromioclavicular joint. So before injecting the joint, I usually start with the non-invasive procedure. If it's effective, well and good. If it's not effective, we can proceed to intra-articular injection. The major bursa we have is subacromial subdeltoid bursa that's present immediately under the acromioclavicular joint. And this is its innervation. And we can put the capacitive probe again in this area before injecting the subacromial bursa. Now, if we move from modern technology back to acupuncture, which has been used for thousands of years ago, you have to forget that you are a professor of anesthesia, you are doing genicular denervation, you are doing ductal canal block and catheter. You have to forget all of these, and you remember yourself as a healer born 2,000 years ago. And for this makes for me a strong relationship with the ex-Chinese ambassador in Egypt, Mr. Song, because he believes that I'm a Chinese person. Anyway, if you go to literature, we have acupuncture for local and distal points. If you are using points on the shoulder, it's called local points. If you use points away from the shoulder joint, it's called distal point. They come to the conclusion that the combination of local and distal is more effective than local points alone. So to understand Chinese, we have to think how they are thinking. They have organs, they have channels, and during these channels, we have energy or qi, blood and body fluids moving through these channels. You have points on the channel. Each point has a specific function. One of the important points is the source point, or the called Yuan source point. And this point, if stimulated, it will improve the energy passage to the affected organ and channel. So some concept of Chinese medicine, the concept number one, that you have one point that's specific for one tissue. For example, in Chinese medicine, they consider the sinew as the muscles, tendons, ligaments, and fascia. So these sinews are very important for any joint. So you have to use the meeting point of sinews, which is gallbladder 34, which is present in the lower limb, immediately below or at the head of the fibula. Another policy that each organ supports one tissue. For example, the spleen supports muscle, heart supports blood vessel, kidney supports bone, liver supports connective tissue and fascia and sinews. So if you have excessive osteophytes, you should use kidney points. If you have muscle weakness, like quadriceps in knee, you have to use spleen points. And these are the Yuan source points of these channels. 3 of them in the foot, spleen 3, liver 3, kidney 3, and heart 7 at the rest or the medial aspect of the wrist. The third concept in Chinese medicine is the organ coupling or the guest host technique. We have 12 channels, 6 of them are yin and 6 of them are yang, and each organ and channel, one yin and one yang, are going together, coupled together. So here we have the gallbladder and the liver. We have the gallbladder channel and liver channel. We have the one source point on each channel that increase the energy to the specific channel. We have another point called low connecting point. The low connecting point of the liver channel supports the kidney channel, and the low connecting point of the gallbladder channel supports the liver channel. So if you are using this liver 3 one source point with low connecting point of the coupling channel, this will give you a great improvement, and it's called a guest host technique. Finally, any channel, or number 4, any channel pass through the shoulder will support the organ. As we said, we have 12 channels, 6 of them are in the upper limb and passing through the shoulder. Large intestine starts from the index finger and passes to the elbow and up to the shoulder and to the face. So large intestine 4 and large intestine 11 and 15 are important for managing shoulder pain. Small intestine is another channel from little finger to the elbow to the shoulder, then it zigzags around the rotator cuffs. So using the small intestine 3 as a distal point, the one source point, with local points here, it's extremely effective if you got a rotator cuff muscle pathology. Again, here we have a third channel which is called Sanjiao. Sanjiao 12, 13, and 14 here on this limb can use for shoulder. Lung 1, 3, and 4, lung 1, 3, and 4 are used for shoulder. Finally, we have empirical points. These 2 are empirical points in the web between the metacarpal bones, between the 2nd, 3rd, and 4th, and 5th. They are extremely effective for back pain and for shoulder pain. We have the stomach 38 in the leg, and this stomach 38 is empirical point that is extremely effective in the management of shoulder pain. And we have a publication that says immediate analgesic effect. You have a patient with adhesive capsulitis from diabetes, and you do press on the contralateral stomach 38, you will find severe tenderness. You do acupuncture for this needle, the patient moves his arm immediately. Believe me, this paper showed that the contralateral side is much better than ipsilateral side. Believe me, press on both points. The most tender point is more effective for such patient. So to conclude, you have to do a mix between modern medicine and between Chinese medicine. You have to follow the concept of the Chinese doctors. Don't think in our modern technology. You have to use the non-invasive technology. It's effective and non-invasive and cover areas that not covered invasively. You have to use the invasive technology, invasive injections, and you have to add to them both pharmacotherapy and physiotherapy. And I hope by this we can have a healthy shoulder joint and treat our patient. I hope I am covered, and thank you, and I'm ready for any question. Thank you very much.
Thank you so much, Professor Muhammad Abdraouf, Cairo University, for this very interesting talk about the use of acupuncture in pain management of shoulder pain modalities. Thank you so much, sir. It's a very interesting talk. And my conference in my faculty 3 days ago was about back to nature. So we have to go back to nature beside the modern ways of and different modern modalities for management of different shoulder diseases. Thank you so much, sir, for being with us.
Thank you for inviting me.
Thank you. It's an honor for me, sir. I think we have no questions. Many thanks, Professor Muhammad, for being with us, sir. Thank you so much, sir.
Thank you.
Our next speaker will be Professor Ayman Farouk from Germany. Professor Ayman will speak about biomechanics of different types of shoulder arthroplasties. Thank you so much, Professor Ayman, for being with us.